Welcome everybody to Rush University Medical Center Division of Nephrology Rush Renal Biopsy Conference for the 3rd of June, 2021. Today's CME activity code is 482649. We have a case Dr. Whittier is going to be presenting shortly. As usual, the case has been de-identified and we have no conflicts of interest to declare. We're gonna do something a little different today. We're gonna have some fun. We're gonna present the case. We'll discuss the case and show the path as we usually do, come up with a diagnosis. And then I'm gonna take a poll based on a clinical issue that's appropriate, I feel is appropriate for this case. And then we are going to have Dr. Glassick and Dr. Rubin debate both sides of the poll answer. So I'm really looking forward to this. I really appreciate their contributions.
Well,
so
debate, it's going to be like Godzilla versus King Kong. I mean, this is going to be a treat. It's like a Rumble in the Jungle or something. Thursday. Are you ready to rumble?
Oh, Bill, once again, you left me speechless. So Bill, why don't you take it over and present the case for us?
It's actually me, Roger.
Yeah,
oh, I'm sorry. Yeah, I'm sorry. It's
I wish I was as good looking as Whittier, but it's me today.
Yeah, I apologize, everybody.
All right. So the patient is a 30-year-old Black woman who is seeing nephrology for evaluation of proteinuria. She reports being in her usual state of health, essentially no past medical history, until when she flew back home to the Dominican Republic to visit her family. This was about a month prior to her visit with us. She reports sudden onset of edema in her face and all her extremities, essentially anasarca, 2 to 3 hours after she landed. During her week-long stay, her edema persisted. Upon return to Chicago, it took a few days for her edema to slightly improve, but it still persisted. So she ended up visiting her internist, and laboratory measurements showed that she had nephrotic syndrome with a protein to creatinine ratio of 4.3 grams per gram and a serum albumin of 2.6. Her serum creatinine was normal at 0.7 milligrams per deciliter. Her SPEP did not demonstrate any monoclonal spike. Her kappa light chain was slightly elevated at 2.5, but she had a normal kappa lambda ratio of 1.6. Preliminary serologic workup, including ANA, double-stranded DNA, complements, HIV, hepatitis, and syphilis were all normal or negative. She's not diabetic. Her A1C was 5.2%. TSH was normal. She has some iron deficiency anemia, which has been attributed to heavy menstrual bleeding in the setting of uterine fibroids. She's taken oral iron for this. Her most recent hemoglobin was 11.8. She has no family history of kidney disease. She denies taking any NSAIDs or herbal medications. She doesn't use any drugs. She works 2 jobs and reports lack of sleep as a major stressor in her life. Her urinalysis is negative for blood or any cellular cast. She has a total cholesterol of 264, LDL of 153 without a prior baseline. Past medical and surgical history, as mentioned, essentially uterine fibroids with irregular menses and iron deficiency anemia. She uses tobacco vape pens, so she vapes. She socially drinks, but doesn't use any illicit drugs. She has no family history of kidney disease. She has no allergies. Her only medication is ferrous sulfate. Her reviews system are positive for facial and extremity swelling. She does also report this foaming of her urine, which is relatively new for her. On exam, her blood pressure is 142/80. Her heart rate is 64, respiration 12. She's afebrile. She weighs 220 pounds and she's 5 feet 4 inches tall with a BMI of 37. Her physical exam, she's a young lady. She's in no distress. She is non-toxic in appearance. She does have minimal facial edema compared to the photos that she showed me on her phone from prior to the onset of her swelling. She has 2+ bilateral lower extremity pitting edema, no skin rashes, no adenopathy. Her labs, sodium of 138, potassium of 3.6, chloride of 103, bicarb of 26, BUN of 16, creatinine of 0.7, glucose of 98, calcium 8.3, albumin 2.3, total bili 0.1, alk phos 70, AST and ALT were normal. Her white count was 8.8. Her hemoglobin was 11.8. She had a normal differential with a platelet of 333,000. Her iron saturation was 23% and her ferritin was 16. Her ANA, ANCA, anti-double-stranded DNA, Hep B, Hep C, HIV, and RPR were all negative. Her C3 was 90, C4 was 24. SPEP and UPAP showed no monoclonal spike, and her serum PLA2R is pending. Her cholesterol is 264 with a triglyceride level of 122, HDL of 87, and an LDL of 153. Her urinalysis shows a light yellow color urine, clear, specific gravity of 1009, pH of 7, 2+ protein, negative blood, ketones or glucose, essentially no white cells or red cells seen under microscopy. Her urine protein creatinine ratio, as mentioned before, was 4.3 grams per gram, and her urine albumin to creatinine ratio was 3.1 grams per gram. Both her COVID as well as her pregnancy tests were negative as well. Her renal ultrasound shows the right kidney to be 11.6 centimeters, the left to be at 10.8 with no cysts, masses, or necrosis. So she underwent a percutaneous renal biopsy.
Great. Any questions? I have a couple here. She flies and she develops leg edema. Did anybody, and then she's found to be nephrotic. Did anybody look for a DVT?
They did. They did Dopplers when she came back. She didn't really see a doctor when she was in Dominican Republic. When she came back, she went to her internist. Part of the workup was also looking for DVT, and that was negative.
And then the urinalysis with 2+ protein, if someone has 4 grams of protein, always makes us concerned about it being non-albuminuria, but in fact, her albumin creatinine ratio is pretty much the appropriate relationship, 3.1 grams. It's hard to believe that 3.1 grams would be 2+. And it just tells you that you have to take the dipstick with a grain of salt. And it's not so much that the urine's that dilute either at 1009. So I thought that was interesting. It's really nice though, because having both the ACR and the PCR, something that we're doing more and more of routinely, it helps us a lot in answering questions like this and help determine how much we believe might be tubular proteinuria versus albuminuria, et cetera. Anybody else have any questions for Dr. Gashty? Okay, Dr. Whittier, since you opened with such a great comedy routine, I want you to discuss it non-comedically.
Well, that'll be hard for me to do because mostly what I say people laugh at. So, the first sentence, 30-year-old Black woman seeing nephrology for proteinuria. I mean, it really, to me, that screams out what young people see us with, especially Black patients. And we think about lupus. And she would, in the beginning there, really falls into this lupus kind of, sudden onset of swelling. We might think it could be lupus podocytopathy. Lupus membranous is certainly up there because of, that would be the most common one in a serologically quiescent patient, which she is. And so I think lupus, even though she is serologically so negative, is still in the differential. And if it was a lupus lesion, I think that's the top two. There's an absence of hematuria. There's a lot of proteinuria. She's got nephrotic syndrome. I think that would all fit. However, if the immunofluorescence is negative, what else could it be? I think sudden onset of nephrotic syndrome certainly points towards minimal change disease. She can be in the right demographic for that as well. When you're thinking about minimal change disease, I would always also throw in the tip lesion with a focal sclerosis, and her demographic fits that as well. So I think those are all pretty high on the differential. Could she have a non-lupus membranous? I think they're teasing us there with the PLA2R pending. So obviously that would help if we had that, but not knowing that. It's in the differential, of course, but she's not quite the right demographic as far as typically we don't think about membranous as much in young Black women, but it could be. She also has a history there of obesity with a BMI of 37, but that really doesn't fit obesity-related glomerulopathy, which is more insidious and not so sudden. So could finally she have something strange or odd, like amyloid or, and I think that would just be a real big leap. I mean, I don't know why she would have a higher kappa chain when she doesn't have renal insufficiency and her renal function is normal, but I don't think there's anything really there. And I'm going to keep my differential limited to that. So I think my number one, even though it's sudden onset and that always points towards minimal change or tip lesion, I think because patients don't always understand that it's sudden onset and they just kind of see edema for the first time on a flight, for example, I think a lupus membranous is probably my number one in the differential.
Can you just elaborate a little bit on this lupus when she has no lupus?
Yeah, I mean, the original ARA criteria were, 4 of the top 12 or 4 of the 12 were needed, and you needed serology, or you needed anemia, or you need, the skin rash and nephritis. But we're realizing that not everybody reads the books, and you can have your first presentation be in the kidney. Those were mostly for studies anyway, which were important because you wanted to make sure if you were going to put a patient with lupus in a study that you were really sure that it was lupus. But we have seen patients who have lupus nephritis without serology being positive, and of those, membranous is the most common one. So the serologically quiescent patients, so for example, if she has a full house membranous, we'll likely call it lupus nephritis, even though she doesn't clinically have lupus.
And, some of those patients will become serologically minimally active later, since we've called that latent lupus. And
yeah,
the truth is, if you don't have any serology and all you have is a full house membranous in the person that fits, I agree with you. That's what I always think the pathophysiology is, but it is a little tough to call it that. But I certainly understand what you're saying, and I think that a lot of people would agree that we've seen plenty of these patients. They're serologically negative, but they fit the profile, and later some of them declare themselves either serologically or something with a rash or arthralgias or something. But I just wanted to.
We see it all the time too with non-renal. I mean, it'll be a patient will present when she's 16 years old with ITP, and then, and maybe she has some thyroiditis at age 22, and then suddenly it's lupus nephritis at age 26. So I think that, it doesn't have to happen all at once. It can happen. These patients aren't suddenly getting all of the features of the disease all at once. And I think that, that has to kind of be thought of.
Years ago, Ron Falk and Charlie Jeanette looked at this whole issue and looked at patients that ended up ultimately having lupus, but didn't have it at the time of biopsy, and compared it to idiopathic patients with membranous. And, they came up with some histologic features that would increase the predictability of it. It's some things like tubular reticular structures, subendothelial deposits, a full house. And so Bill's right. I mean, but it's based on the biopsy findings. And I think Babette Degotti's kind of recently kind of revisited these various features that might predict somebody that has lupus nephritis, even though they don't have apparent serologic or clinical lupus.
Yeah, IgG subtype, I think probably you could add to that list, and mesangial deposits as well. And that's why I think we all feel comfortable with that, because those things are not typical for what we've routinely considered idiopathic membranous.
The thing about Charlie's paper is that any one of those features wasn't enough. You had to have all 3 of them to have a high predictability.
All 3, you want to say all 3 again?
Tubular reticular structures, I think, full house and subendothelial deposits.
Yeah, that's a pretty strict one though, because even in lupus we don't always see tubular endothelial deposits and subendothelial deposits. I mean, really, that's almost that's a punt, and those are easy. I'm talking about the ones we don't see, where we're basically seeing a membranous with a few mesangial deposits and some mesangial hypercellularity, and maybe if you do IgG subclass, it might be off a little bit. I think.
But it doesn't mean you don't still follow them. It was just they were trying to figure out a set of criteria that would increase the predictability in someone that didn't apparently have lupus serologically or clinically, but this is what they saw in the biopsy. So yeah, it doesn't get away from the fact that you would still want to follow someone.
No, it is what it is, and I think it's just an important point, because a lot of people would listen to this, and they're, like Bill said initially, there's ARA criteria, and a lot of patients that we would say clearly have lupus may not even fulfill criteria, because all they have is something that we know exactly that is associated with nothing else. But remember, these criteria were not written necessarily for patients. A lot of times they were developed for studies, so that when you have got borderline patients to put in a study for, say, lupus, you have to have enough criteria to put somebody in there. So, and nature didn't just decide these criteria. But I think you also have to be careful with criteria for any disease. They serve a purpose, but they shouldn't be dogma or exclude a patient from that diagnosis by not fulfilling criteria. That's my opinion. Anybody else have any thoughts on this? Nope. Okay. Well, I mean, we should take a look and see what we got here.
Well, did somebody bring up collapsing FSGS? I don't know. Bill may have brought it up. I didn't hear it.
No, I didn't. I talked about the tip lesion and the sudden onset with minimal
Because-
change as well, but go ahead.
No, I'm just going to say in this age group, being African-American, that definitely it's higher than the tip lesion would be in somebody, that is African-American with nephrotic syndrome that's sudden and onset. You'd expect the creatinine ideally to be a little higher, but if you're catching the patient early on, it may not be. But I think in a 30-year-old African-American female who comes in with sudden onset nephrotic syndrome is hypertensive, I think collapsing FSGS has to be in there somewhere.
Yeah, I glad you brought it up because I pretty much excluded it based on the creatinine, but I don't have necessarily can support that. But it just seems to me those patients always they're a little more nephrotic and they're a little more renal failure.
Yeah, and we're not necessarily talking about treatment yet, but if you do catch the tip lesion early enough like this, then it actually has a lot better prognosis than if you catch it late. And there's some data to suggest that the reason it's associated with such a poor prognosis is because a lot of the patients got presented a little bit later. So don't think I'm sorry, I meant to say collapsing. Don't think just because it's collapsing that we give up and there's a no prognosis and it doesn't require treatment. Especially early, they can be treated pretty successfully.
Sounds good. Neurali, is she on today?
Yeah.
This is the Trichrome stain. We are looking for the chronicity and if there is any global sclerosis. We have two cores here. I see a couple of gloms, lot of gloms. None of them are globally sclerosed, so at this power. I don't see much blue staining material in the tubular interstitial area, so not much fibrosis, and with this patient having overall good renal function, I think it goes with it. So I would say maybe less than 10% or maybe 10-20% of EFTA.
Neurali, really, there's none. I mean, the little bit of blue staining is around some vessels in the bottom. That's just supported connective tissue. So yeah, there's no fibrosis.
Don't say 10% when there's none. Dave will call you out.
Yeah.
Okay.
The devil's in the details, Mel Schwartz used to say.
So this is the low power. Is this PS or H&E? It's difficult to.
That's an H&E.
H&E. Okay. At this low power, I see 1, 2, 3, 4, almost 10 gloms. And tubules are back to back, not much interstitial inflammation or fibrosis. So overall looks okay.
Okay, good.
This is H&E stain, high power. We are seeing one glom here and half of the other here. The loops overall glom looks okay to me. The capillary lumen is it's patent open. Membranous is in a differential, so I'm trying to see if there is like thickened basement membrane like the capillary loop. Maybe not. So overall,
on an H&E, it's kind of hard to tell the capillary wall if it's thickened or not. But sometimes membranous they're a little extra stiff, or even more round, almost looking too good or too pure. George Dene used to call them proud or almost lead pipes. Do you see that here? Or do you think they're just
maybe here? Here it seems a little more like how you were describing, but not very well. I'm not able to appreciate. Maybe here, I'm not sure.
David, what do you think? Do they look proud to you?
It's subtle. They look minimally thickened to me, I would say.
Not proud. Subtle is not proud.
Yeah.
Okay.
Yeah, I mean, there's some that's obvious lead pipe rigidity. Not the case here.
Okay. So the capillary architecture overall is normal. The mesangial area, it's the cellularity and the matrix looks normal as well. So since we had like lupus and other secondary causes, it doesn't seem like that. Like at this power for this glom, the mesenchyme and capillary both are normal, and the surrounding tubules look okay as well.
Okay.
So this is a Pier stain with one glom here and couple of tubules around. I don't see any arterioles. So looking at this glom, I think hilum is here. Um, I'm trying to see if the capillary lumen, the basement membrane is thickened and more like stiff. Maybe at focal in some places, but still not very well able to appreciate. But otherwise, it's open. There is no endocapillary proliferation. The mesenchyme is normal as well. No hypercellularity. Surrounding tubules and interstitium is normal, back-to-back tubules packed.
How
So-
about the bottom left? What's that structure?
This,
Actually, yeah, you have part of a interlobular artery. You could see the media there, some muscle in the bottom left corner. If the arrow moves down there, yeah, you could see the intima is right on the media. There's no fibrosis.
okay.
Bottom left corner of the screen. Okay.
Sorry. Yeah. So this is the Jones stain, silver stain, with membranous and differential. We are looking for holes for the deposit and spikes as a reaction. I see few spikes here.
Go over to
Maybe
2
more
o'clock.
here.
Go over to
yeah.
2 o'clock. What do you see over there? Yeah.
Yeah, spikes here, holes also.
Holes. Yeah, yeah. That's
Yeah,
on
yeah.
FOSS. Yeah. You see some holes there.
Yeah. But
Spikes
not
aren't
very
the spikes aren't
prominent.
as prominent or
Yeah,
obvious, but you do
Yeah.
see some areas of holes.
more holes. Yeah.
Remember, this is a pretty, I mean, granted we're seeing holes. I don't see many spikes, and we don't want to, I suppose at this point, you may be able to throw out the diagnosis of minimal change, but up to this point, I'm not so sure you would be able to do that. I don't think it's fair to, we spent a lot of time talking about lupus membranous, but there is a broad differential diagnosis here. So, but yeah, I think, I can imagine some spikes, and I definitely see holes.
Okay. Yeah. But I don't see anything else otherwise. No splits or double contour.
Okay.
Sorry.
Oh, yeah, too fast.
So this is the immunofluorescence, positive, granular, diffuse, and the capillary basement for IgG. Mesenchyme, not so. So it's just a capillary wall, and it's diffuse and granular.
Yeah. So what is this diagnostic of? If you had this picture on an exam?
It would be membranous.
Yep.
And we have PLA2R staining, which is positive. Yeah. And it's diffuse capillary wall. So.
Yeah, it was not full house. The IgM and the IgA were negative, as was the C1q.
Wow. So this points to the primary membranous then for our patient.
Or what we're now trying to move towards is the antibody, and so you could actually say this is PLA2R positive membranous.
Okay. We have electron microscope. So this would be the urinary space, capillary space and the urinary space. The basement membrane looks thickened. I don't know, but it's definitely much thickened more in some areas. And there are electron dense deposits. It looks subepithelial, and those are large. So large subepithelial electron dense deposits, thickened GBM.
Yeah, right where you're at. Yeah, can you point out
Yeah.
the spikes? Yeah, you see, yeah, exactly. The basic membrane reacting around the deposits.
Yeah. So a lot of them, and it's all over diffuse here, tracing the GBM.
And then where's the
foot process.
mesangial area? Any
The mesangial
deposits?
area would be this.
Yeah.
Yeah. And we don't see any mesangial deposits.
Correct.
No no subendothelial deposits as well. So it's just these subepithelial. And looking at the foot process, it's I would say almost gone, like diffusely effaced. Maybe there are a few places where it's still intact, but otherwise it's pretty diffuse, like foot process effacement.
Yes.
I'm surprised that the silver stain was so normal with these kind of huge deposits. I mean, you can clearly see some what would be spikes and
Yeah.
on these basement membranes.
This is the another EM, higher power. So blood space, urinary space, GBM, thickened GBM with electron dense deposits. Yeah.
Yeah, subepithelial.
Subepithelial. Anything else or? Yeah.
And then can you point out the fenestrated endothelium? Yeah, there it is. Yeah, no TRIs were seen.
Yeah. Okay. Yeah. Here, tracing.
Yeah.
So diagnosis would be PLA2R positive primary membranous in a young African American patient.
Yep.
Great. So, we don't always have the PLA2R before we do a biopsy, and that's a point of contention. Do we wait for it? Do we make decisions based on it? So before we talk about that, in this case, I do want to put a poll out. We'll find out later what it is, but I want to put a poll out. And basically, if you're a member, if you're a co-host or a host, in other words, faculty, Dr. Glassick, Dr. Rubin, et cetera, don't vote on this. Just leave it alone. But this is for everybody else in the audience, and please vote. You have a patient with nephrotic syndrome and pre-biopsy workup demonstrates a positive PLA2R antibody via ELISA. Choose one of the following. I would still do a biopsy, or a kidney biopsy is not needed. We'll give it some time. Please vote. I want to have a good representative here. Get a few more votes. We got 50 people. We got 20. We got about 30 votes. Okay, so ending our poll, we've got about 2/3 of the people would still do a kidney biopsy, and about 1/3 said a kidney biopsy is not needed. So what I gave a whole day's warning to our two superstars here, Dr. Glassick and Dr. Rubin, to debate this topic. And I gave Dr. Glassick the kidney biopsy is not needed, the 1/3 option. And I gave Dr. Rubin the 2/3 option. I would still do a kidney biopsy. And so I think we're going to debate this at this point. But to decide who goes first, I'm going to spin the wheel again. This is a multi-purpose wheel.
This is great.
I don't think they ever really wanted to be on the wheel, but they are now.
Okay, Mario, you're on. Mario Rubin, who's taking the approach biopsy is still needed. We'll begin the debate. You are not on a timer, by the way.
Thank you. All right, Javier, let's see the first slide. So, one of the dilemmas whenever we consider a biopsy is the complication rate. And these are, over the last 10 years, the two largest meta-analyses that have looked at this issue. On your left-hand side is a former fellow of mine from MGH, Christine Korapi. They looked at 9,500 patients, and you can see the incidence of gross hematuria and transfusion. Somehow, they didn't look at the death rate. On the right-hand side, you see data from Emilio Poggio, who gathered a large number of people. They looked at almost 120,000. And as you can see, yes, I mean, you can see bleeding, but hardly ever people die from the biopsy. Next slide. So in terms of the PLA2R, this is data presented by Jonathan Hogan from Penn. He actually discussed this. He was a proponent of doing a biopsy in Kidney 360 back last year. And the purpose of this is to clarify that there are actually three methods of measuring the PLA2R. One is the Western blot that is too costly, is too cumbersome, so it's only performed for research purposes, if at all. And then we have the ELISA, which is a quantitative assay of PLA2R, and the indirect immunofluorescence on the right-hand side, which is not widely available till very recently, and I think Dr. Glasser will tell us more about it. And there are the values that we look at, which are, correspond to what the Western Immune Society is looking at. The Mayo Clinic is looking at much lower values to differentiate positive from negative, but in essence, most people that get Quest or LabCorp assays, anything over 20 is positive. The other thing to note is that PLA2R can be falsely negative in diabetes. Next. This is data presented by Andrew Bombach from Columbia, and you know, it's interesting. Back in 2018, he already pointed out at the very top that if you have a patient in whom a kidney biopsy can be problematic, then it will be okay to proceed with the kidney biopsy if the, I mean, it would be okay not to proceed with the kidney biopsy, even though your PLA2R is positive. And then he goes into something that we are all too familiar with, which is to use the PLA2R antibody titer as a marker of when to initiate therapy, whether or not the disease is in the process of remitting or relapsing, whether it's recurrence in an allograft, etc. So that information is quite helpful. Next slide. Now, this points out that the findings on the kidney biopsy in primary membranous could be predictive of prognosis. In the case we were shown today, there was not much in terms of tubular interstitial disease or vascular disease or focal sclerosis as a complication. But if those findings are present, that implies a poor prognosis. Next slide. Now, the issue of biopsy or no biopsy came from this retrospective study from the Mayo Clinic published in KI in 2019, where they looked at patients in Rochester, in Jacksonville, Florida, and in Arizona, the three Mayo centers. And out of 838 patients, 143 tested positive for the PLA2R. They found secondary causes in 35% of the cases, most commonly being malignancy and autoimmunity. The majority of the patients, 97, had a negative workup for secondary causes of membranous. And 60 of those 97 had an EGFR greater than 60 and were considered to have normal kidney function. These patients did undergo a biopsy, and it did show, with the exception of 2 patients, a membranous process. The 2 other patients showed FSGS, one of them, and diabetes, the other. And those that had abnormal kidney function were 37 of them. The EGFR was less than 60, and there were other processes such as interstitial nephritis, diabetes, crescentic GN. So what they concluded is that patients with a positive PLA2R, no evidence of a potential secondary cause such as infection, drugs, autoimmunity, etc., then they will not need to be biopsy because most likely they have a membranous process. Next slide. They came up with this algorithm, as you can see on your left-hand side. If you suspect membranous, you do, and this is key, by the way, and they do a screening indirect immunofluorescence study on your left-hand side. If that is positive, they went ahead and performed a PLA2R via ELISA. And if that is positive and they consider positive anything greater than 2, then the diagnosis is membranous and you don't need to do a biopsy. On the other hand, if the indirect immunofluorescence is negative and you do need to perform a kidney biopsy and go from there. So in other words, you need both tests, the indirect immunofluorescence, which till very recently was not available commercially, as well as the ELISA, which obviously not everybody except at Mayo has that luxury. On the other hand, on the right-hand side, if you do not have the indirect immunofluorescence test available to you, then you can use the ELISA. And if the ELISA is greater than 20, most likely you have membranous and you will avoid the renal biopsy. On the other hand, if it's less than 20, then it depends upon what your indirect immunofluorescence is. And if it's negative, then you need to go for the biopsy because you don't have that highly prediction that this is going to be membranous. Next slide. Now, Jonathan argued that the PLA2R assay has not yet been properly validated in terms of what is a high value, what is a low value, how does it predict the illness in different types of populations, and also that he felt that it requires validation in other prospective cohorts that also suffer from the nephrotic syndrome. And I frankly tend to agree with it. Next slide. Now, an editorial to the paper from the Mayo was written by Brad Robin in that same issue, and he very nicely points out that the kidney biopsy not only will show us the histology on light microscopy, immunofluorescence, and electron microscopy, but has gone beyond that. We are in the area of molecular pathology, And we have learned, for example, a lot from kidney transplantation by the work that is being done in Alberta, that the identification of certain transcripts is much more predictive on kidney tissue of rejection or other processes. And the same begins to apply to nephrology in general. Next slide, please. Sanjay Sethi has recently published this interesting concept that membranous, much like membranoproliferative, is not just a single disease, but it is a pattern of injury. And, you know, the disease will be different depending upon the marker. And so PLA2R will identify in 70 to 80% of the cases primary membranous. A thrombospodin will identify neoplastic process. Exostosin will identify a membranous lupus. So and so forth. Next slide, please. So this is a slide of his that he recently tweeted, where he performed immunohistochemistry and he's able to identify the NEL1 biomarker, which is a marker of a membranous potentially associated with malignancy. Next slide. And today he shared this other production of semaphorin, which, as we know, is a marker of membranous in the pediatric group. So we have advanced quite a bit, and we should not deprive ourselves from what histology provides. Next slide. Now, back in 1986, a commentator was describing the World Cup in Mexico, and there was this fabulous goal from Diego Maradona from Argentina, and he called that sheer poetry. I want you to read these papers, one by Mel Schwartz, well known to the group at Rush, which is an outstanding description of membranous in the Heppenstall 4th edition back in 1992. I mean, it's worth reading, I tell you. And the other one by Heinrich Chert regarding the evolution of the glomerular lesion. So I still think that biopsy for the time being is needed. And maybe down the pipe when PLA2R is validated across populations, not in a retrospective analysis such as the Mayo one, but in prospective studies, that might be another story. Thank you.
Thank you. Dr. Glassick, your turn. Muted. You need to unmute yourself.
Can you
Yes.
see my slides or not?
We have your desktop, but not your slides yet.
Okay, just a second. Just a second. Let me get this taken care of here. Okay. All right. There we go.
That's a desktop if I've ever seen one.
All right. Am I on now?
You are.
I am.
You are on. If you want to just make your screen the full presenter
Okay.
mode. Yeah. Perfect.
Okay. Perfect. Okay. Thank you. Well, what Dr. Rubin has said is very valuable information, and what the poll shows is interesting as well. I do want to stress that polls, like political polls, don't always tell the truth. And the question here is really, if a kidney biopsy would not contribute in any material way to your management, would you expose yourself to the risks of a kidney biopsy, such as a 1 to 40 chance of a blood transfusion, a 1 in 15 chance of an adverse event, maybe a 1 in 20,000 risk of dying as a result of the kidney biopsy? In other words, it is a risk-benefit consideration. So the question I think that is relevant here is, does a positive serological test for anti-PLA2R antibody result in a very confident diagnosis of a membranous nephropathy lesion? Dr. Rubin's consideration of all of the other antigens that are seen in anti-PLA2R negative cases is really immaterial to this decision, because we're only talking about the patients with positive anti-PLA2R serology. Now, Dr. Rubin showed you a slide of the algorithm used by the Bobart-Fravenza group of Mayo Clinic, derived from a study of 838 cases in the Arizona, Florida, and Minnesota cohort. 92%, by the way, were non-Black. Very few patients in this series were of the Black race. And when both ELISA and indirect immunofluorescence tests were performed by the commercially available assays, and I want to emphasize, these assays are readily available. Quest Laboratories has a code number 93875 that allows you to order these tests as a panel with a good turnaround time. So saying that, you know, both tests, particularly the indirect immunofluorescence, is not generally available is just simply not true. It's available routinely and it's FDA approved. So if you have an ELISA of greater than 20 relative units, by the Euroimmune assay, 100% of 102 patients had a membranous nephropathy lesion. If you had intermediate values, greater than 2 and less than 20, but still had a positive indirect immunofluorescence, 100% of patients had a lesion of membranous nephropathy. And if you had a perfectly negative ELISA, but a positive indirect immunofluorescence, 100%, but of course the number of patients in this study who had that particular circumstance were very uncommon. 20 relative units, even in the presence of a negative indirect immunofluorescence, was associated with a high predictive value, in this case, 100%. So the statement that if you have an ELISA assay greater than 20 relative units, whether or not you have a positive or negative indirect immunofluorescence, leads to a 100% predictability of a lesion of membranous nephropathy. Now, in a patient who has all other potential secondary cause of membranous nephropathy rendered unlikely, as was the case in this series, lupus, diabetes, drugs, infection, and malignancy, what is the value of renal biopsy in determining management? Well, it's really none, because you can predict with virtually 100% accuracy that the lesion encountered in the biopsy will be membranous nephropathy. And I think that applies to this particular patient, with the proviso that this patient was obese and was of Black race. And the data from the Mayo Clinic does not lend itself very well to an analysis of the racial contributions to the predictive ability of anti-PLA2R serology. But if you take this data, as I have expressed here, and apply it to this patient, recognizing that there is no racial predilection for the development of membranous nephropathy that I know of. This patient had a anti-PLA2R antibody been done prior to biopsy. Kidney biopsy could have been safely avoided, and the patient managed entirely on the basis of clinical findings such as proteinuria, kidney function, and serial measurement of anti-PLA2R. Now remember, this patient's serum creatinine was normal. If the patient's serum creatinine was abnormal and the eGFR was less than 60, then I think a biopsy would have been necessary because there may have been complicating factors that would contribute to a difference in management. I think I'll stop here rather than beat a dead horse, an already dead horse to death, by just summarizing that, in my opinion, an ELISA test, preferably combined with an indirect immunofluorescence, should be a prerequisite prior to making a decision about a renal biopsy in a patient presenting with nephrotic syndrome of undetermined cause, in which membranous nephropathy is a part of the differential diagnosis, and in patients who have normal renal function to begin with. Thanks.
Thanks, Dick. Well, that's 100% is 100%. It's always hard to believe there's 100% of everything. Praveer, can you put up the poll again?
Yeah. The results or the relaunch it?
No, let's relaunch it. Let's see if we've changed anybody's mind.
So Dick, one thing I found out, both Mario and Dick's presentation, that article, which I remember when it came out, that I find interesting is that even with the PLA2R positivity, the caveat is still you have to rule out secondary causes, which gets back to the issue of, how specific is the PLA2R relative to these other causes that we still used to, that we used to rule out. And there was a time that it was being kind of touted that if they were PLA2R positive, there's no way they had any secondary form of membranous. But yet, this article, as you both brought up, the caveat is always rule out secondary causes. So then we get back into the issue of if they're PLA2R positive and we don't do a biopsy, to what extent do we, what secondary causes do we rule out? We're kind of back to square one. Do we rule out malignancies in everybody, lupus, et cetera?
Well, Steve, a good point, and I'm anxious to hear what Mario would say, but in the series in the Mayo Clinic, the exclusion of secondary causes was based on a good history, a physical examination, a list of medications, serological studies, anti-nuclear antibody, anti-DNA, studies for viruses, and routine preventative measures for assessment of cancer. All of the things that were done in this patient. This patient would fit in very well with the Mayo Clinic series because all of the studies were done to evaluate a possible secondary cause. And a kidney biopsy is not going to help in any way in determining whether there is secondary or primary forms of disease.
Oh, no, I couldn't agree more with that. My only issue was that the PLA2R is not an absolute anymore, that that it could be nothing else. And I think that's kind of, originally it kind of was touted as being that. And I think people have backed off on that a fair amount.
Yes. Well, I'd like to hear Dr. Rubin's response to this because he attempted to make a case for a continued biopsy in the face of a patient like this who had a positive PLA2R antibody by ELISA. Now, the provision was greater than 20 relative units per ml. Now, if you have a much lower level of PLA2R, between 2 and 20, which is uncommon, you really should do the indirect immunofluorescence assay as well.
I'd like to point out too that your algorithm is based on having a indirect immunofluorescence, which we didn't have here. We just had a PLA2R. So Mario?
Well, the problem I have is that this is only one study is retrospective. And as Dr. Glasser pointed out, it mainly encompasses a Caucasian group of patients. So I'm not so sure that we are ready to generalize and utilize these study results as the gold standard. I just think that additional studies across different population of nephrotic patients need to be done. What was the result?
Mario, if such a confirmatory study independently confirmed in every way the Mayo Clinic experience, would you then accept anti-PLA2R antibody assays as a substitute for kidney biopsy?
Yes.
Okay. Well, I can tell you that such a confirmatory study is in the process of being published.
Okay.
You have insider trader information.
That's all I can say.
I don't know if that was fair. I apologize to Mario. I didn't realize.
No, that's fine. That's fine.
So the repeat poll, the results kind of reversed, but that's not always fair either, because people tend to believe the last thing they heard, and we all know what polls do. They don't tell everything. You know, talk is cheap, and it's easy to say I wouldn't do it. It's really a hard thing to do. I think it's easy if you've got a patient with complications who might be complicated, obese or coagulopathy or something, but to avoid it. But it may not be so easy. So for the sake of time, Casey, why don't you tell us what the PLA2R was in the blood and what you did with it and how your decisions were based on that?
So after the biopsy, obviously, the PLA2R came back and the level was 35, so it's positive. And it's not tremendously high, but it's over 20, so it's 35, positive. So I guess the next question here would be, how would you treat this person? Because, this is a fresh membranous with a is a positive, but not super high level of PLA2R and about 4.5 grams of protein and 2.8 albumin. So, I'm curious to know how people would manage this. Would you jump to Rituxan, or would you try RAS blockade for 6 months and then go to Rituxan?
You've heard my opinion. Why don't you tell us what you did, and then we'll see.
I put her on an ARB. A month later, proteinuria is 2.8 grams, so it's a little less. Her albumin is about 2.93-ish, and her edema is better. She's on Lasix and statin. So I haven't actually given her Rituxan yet. I'm going to give her the 6 months and then decide.
So this whole 6-month thing was before we had such a good treatment. We always had Ponticelli, but people were afraid to use that. So they always wanted to wait 6 months on an ACE and ARB and see how they were doing, except if they were very high levels of proteinuria. And I don't know that we know that the PLA2R has changed that, but I think in a lot of people's minds it's changed it based on the level. And I think your point is it's a pretty low level. And you feel much more comfortable doing the 6 months. If this PLA2R was, say, 1,000, would you treat it right away?
Yeah, I would.
I see Mario shaking his head. Dick, is there a cutoff where you would not treat or not based on the PLA2R?
Well, I'm anxious to hear what Mario says, because this is a pretty controversial area, but the data so far suggests that you're in the lower tertile of antibody levels in relative units. The likelihood of a spontaneous non-treatment related remission is higher. Therefore, observation might be indicated if there were no compelling reasons for treatment, like severe hypoalbuminemia, declining GFR, or a thromboembolic event. And in patients with very, very high levels, there is some reason to suggest that rituximab may not be the first choice. We need, I think, more data. I think a conservative approach might be indicated in a patient like this, depending upon her wishes and preferences. But I think if I were to treat it, I would use rituximab in this case and not cyclophosphamide. She's a young woman. She doesn't deserve to be exposed to the potential effects of cyclophosphamide, but I wouldn't treat.
So I think you made two really good points here, and that your decision might not may not be based solely on the PLA2R level, but certainly influenced by it, but also the symptoms. And then the other would be if it was very high, that there is evidence that that a Cytoxan-based protocol might be the first way to go. And I know there's some more evidence for that now. And I think those are all really, really good points. And I think that if you were to treat her, I agree that that the Rituxan, because she's young and would make a lot of sense in trying to avoid this. But I think Casey's got a good plan there. I mean, she's not that nephrotic. Her level is low. She has a much higher likelihood of spontaneous remission. And I think, there's no rush here. So I think that makes a lot of sense. Anybody have any more comments? Now we'll wrap it up.
Hey, Mario,
There
thank
was
you.
a
Thanks very much, Mario, for taking the position of that you did. And I think you did an elegant, you had made an elegant argument, but I must say, I do have a different opinion.
Well,
fine.
I feel like the parent here. I feel like I'm the parent here, and I can't make a call on who I think won the argument. But I do want to thank everybody, both you guys. I asked you yesterday morning if you'd be fun, and you both had, you're both game and great sports in this. I really do appreciate that because I think it adds a lot to our discussion. Someone else is piping in.
Thank you.
Thank you.
Well, then I'll wrap it up. Thanks, everybody. The CMA code for today was 582407. Thanks for everybody coming in, and thanks for all the participation, being good with the polls. Thank you, Prevere, for running all the technology and all the post-production work that you do. We'll see everybody possibly next week. Just follow your email and be safe and get vaccinated, and encourage everyone else to be vaccinated. We're almost over this. Thank you.
Thank you.